This lecture is on vestibular disorders. We're going to start off by reviewing the structure of the vestibular system and the circuit from inner ear to brainstem and then to wherever it goes from there, either up or down. So we'll have our three neuron diagrams, but there will be about three of them that we need to go through. Then we'll talk about a few select disorders of the vestibular system. The most common being the benign paroxysmal positional vertigo, but then we'll also talk about inflammatory damage to the nervous, to the cochlear, Jesus Christ, inflammatory damage to the vestibulocochlear nerve, and finally we'll talk about what happens whenever we have an accumulation of fluid within the membranous labyrinth, and that would be our endolymphatic HYDROPS there. We can see an image of the inner ear here, so that's going to be shown in purple. What we're going to have is our vestibule. Then we'll have three semicircular canals coming off of that. We have our anterior and our posterior. They kind of join up here. And then we have a lateral canal right there. There's a couple of different sensory organs within the vestibule that are going to sense static head position, and within the semicircular canals, this is where we're going to sense movement. So there will be a few swellings called ampulla, and these are going to be the sensory organs that sense movement. So whenever we turn our head, this is what's giving us that sense of movement. So the special sensory organs are going to be the ampulla in the semicircular canals and the maculae here in the vestibule. I'm not going to draw the cochlea here because that has to do with hearing. We'll touch on that right at the very end, but I want to leave that out of it. We'll talk a whole lot more about the function of the inner ear next semester in neurobiology, but for now we just need to get the basic sense of what the parts of it do. The vestibule is going to sense static head position. Am I pointed up? Am I tilted? But the movement, the change in position, is going to be sensed by these three semicircular canals. They're essentially oriented in X, Y, and Z to detect three-dimensional movement. Based on the movement and position of our head, that's going to control the movement of our eyes, neck, and body in order to keep us upright and to fix our gaze wherever we're looking. But the inner ear is made of pretty much two components, both of which we call a labyrinth because of the kind of complex winding structure. So it's similar to the labyrinth or the maze. The bony labyrinth is made of bone, and that's the hard outer covering. If you look in the illustration here, they're showing it kind of yellow. That surrounds the whole thing. And through the magic of illustration, we can see the blue membranous labyrinth there. So this is a bunch of cell membranes. It's going to have a few select sensory areas that I've already highlighted here. So we got these swellings in the semicircular canal, the ampulla there, and then we have our maculae that are going to sense static head position in the vestibule. So that's where the magic happens. The cochlea also has sensory organs as well. Now if you were to just slice through, you'll see the cartoon on the bottom there. So the outer covering, let's say we just do a cross section through one of these semicircular canals or the vestibule, doesn't really matter. They're all basically the same. You have your outer bony labyrinth. That's going to be made of bone. Then you have your more delicate membranous labyrinth here. This is where the magic happens. Surrounding our membranous labyrinth there, we have what we call perilymph. This is your typical extracellular fluid, low potassium, high sodium, and then we have our endolymph. This stuff is special. This has high potassium. This is going to be very useful next semester whenever we talk about the actual movement of ions and how our inner ear senses head position and sound. So we have a few different types of fluid in there. We have a bony outer covering to keep everything safe, and then we have the membrane, within that that's going to actually have function. So everywhere in our inner ear we have a bony outer covering and membrane on the inside that does all the hard work. So we're going to start off in the vestibule. This is where we're going to sense static head position. So the sensory organs here are going to be the maculae, and we have two of those here. There's the utricle and the saccule. Now what these are going to do is sense gravity. And so we can see in the animation that's going here, there's these little bits of ear sand called otoconia, and those are going to be pulled down by gravity. Now these are oriented 90 degrees from one another, so when we're upright, the utricle is going to be more sensitive to changes in head position, and when we're, for the saccule, let's say sleeping, or just lying down, but I want to match the letters. Utricle for when you're upright, saccule for when you're sleeping. So when your head is turned 90 degrees, that other macula is going to pick up the slack there. So we're sensitive whether we're upright or lying down to these little changes in the angle of gravity. That's what we're sensing. So when gravity is down, we get a certain degree of output from the utricle. But as we turn our head a bit, the angle of gravity changes, and that changes the direction that the ear sand is being pulled. And what that's going to do is change the output of these specialized hair cells within the macula. So if we were to look in on one of these, let's just go ahead and zoom in. We're going to have a hair cell, and it's going to have these little stereocilia embedded in a gelatinous membrane. There's our otolithic membrane, and we're going to have grains of sand sitting on the outside. These things have weight on them, and they're embedded in the membrane pretty well. They do come out, and we'll get to that later, but gravity's pulling them down. With changes in head position, they're going to get pulled down more or less. So if we don't have gravity pulling straight down, instead we turn our head and now gravity's at this angle, the amount of downward deflection in this vector is going to be reduced. So we're not pulling down as hard, so the amount of neurotransmitter we're releasing would be reduced, and that would translate to a change in the 8th cranial nerve. So for the macula here, just think, what's the angle of gravity? And that's how we can tell the angle of our head. The saccule does the exact same thing. It's just going to be oriented to different angles. Now the head movement is going to be picked up out here in the semicircular canals. As we move our head, we're going to essentially move the canal, and the endolymph inside it is going to kind of stay still. It's going to drag a bit. And that's going to push on a specialized little structure in these swellings called the cupula. So think of this as like a sail. All right, it's a day at the beach. We got our sand, we got our sail here. So that as we move and the fluid, let's say, pushes on this cupula here, that's going to deflect it. So rather than having gravity push on the hair cells, in this case, now we got our cupula, and when the fluid pushes on it and pushes this over, that's what deflects our little stereocilia here, changes membrane potential, and determines how much neurotransmitter we spit out. Again, cranial nerve 8 is going to be stimulated. I don't want to go into too much on how this actually works. We'll get this next semester. For now, just think sand is going to detect gravity for static head position, and these little sails are going to detect movement of fluid to tell us the movement of our head. So we have 3 different semicircular canals, anterior, posterior, and lateral. And to remember those, just simply flex. So this is essentially the angle of your lateral canals, your right and your left. For the anterior and posterior, give it a flex and turn a bit. and then turn a bit this way. So we got anterior, posterior, anterior, posterior, and then lateral, kind of like that. So they're essentially oriented in X, Y, and Z. So we can detect 3 dimensions of movement. So here's a little animation that's going to show us that. We got 3 semicircular canals for the 3 dimensions of movement. And so as our head moves, as we're rotating our head, we're going to be rotating those canals. Now, rotating your head laterally is going to most sensitively change the fluid in the lateral canal because it's able to move in that axis of rotation. But it doesn't do a whole hell of a lot for the others. On the other hand, nodding is going to move the fluid a whole lot more in your anterior and posterior canals compared to your lateral. So they're going to pick up different directions of head movement. Depending on whether we're rotating in their axis or not, that's what's going to determine how much the fluid moves, how much that endolymph moves and pushes on the cupula, as we can see here. As we move the cupula, we stimulate the hair cells, we stimulate the 8th cranial nerve, and from there we project inward to the brainstem and hit the medulla. So, all of these components, whether you're connected to a cupula or you're connected to a macula, these are all going to form the 8th cranial nerve, at least the vestibular part of it here. There's also a cochlea sitting in the way, but we're forgetting about that. That's going to also create the 8th cranial nerve. This is going to project inward. So we're going to go from the inner ear into the brainstem. So this would be our primary vestibular afferent. And they're going to live out there in the vestibular ganglia, very close to the inner ear. This projects into the ponto-medullary junction here. We're going to hit our vestibular nuclei down in the medulla. Here's our medulla, here's the pons. So here's our secondary vestibular afferents. And we can divide the vestibular nuclei up into different components, superior, inferior, medial, lateral. And they're going to have slightly different projection patterns. But in general, those that are on top tend to project more upward, and those that are on the bottom tend to project downward. Because now we have a choice to make. So we're still going to hit our 3 neuron pathway pretty much. But from here, we can either go up or down or kind of stay in the brainstem. Now, since we're on this slide, is the vestibulospinal tracts, you can probably tell we're going down into the spinal cord. So from the vestibular nuclei to the spinal cord, that's your vestibulospinal tract. So the downward projection here is going to hit that 3rd neuron, and that's going to be lower motor neurons in the spinal cord. Depending on which component of the vestibulospinal tract we're talking about, that's going to determine which lower motor neuron. So if we're bending over, let's say we're playing a game of pool. When you bend over the pool table, you can keep your head upright. It's no problem. And you'll also keep your sense of position as you're moving around. That's because of our vestibulospinal tracts. So we're going to hit lower motor neurons that help control the neck. So that as we bend, our body will bend our neck as well and keep our head upright, if that's what we want to do. And you don't have to give it much thought. This is essentially a reflex because you'll notice nowhere have we gone up to the cortex for any of this. So this will just run automatically. We can also hit lower motor neurons that are going to innervate the trunk to help keep us upright. So that as we bend, we can keep our center of gravity over our legs there. So we can have a little bit of tension so we don't just fall forward. And speaking of legs, we're also going to innervate our legs. Now, of course, this is not the same motor neuron innervating all these. We're going to hit different parts of the spinal cord. And these are going to help keep us upright. That's what this is all about. The vestibulospinal tract is about keeping us upright as we move around. Whether it's bending over or leaning, it doesn't matter. As we're moving our center of gravity, we want to make sure we don't fall over. But we also don't want to have to think about that junk. So we have this non-conscious descending tract here that starts in the inner ear, goes to the medulla, and then eventually hits the spinal cord to keep our sense of balance. And this thing is really nifty for being able to do stuff like walk and not have to think about it. So this is something that we'll pick up, and we'll refine this over the years as we go from newborns who can't walk to toddlers who can, but not that well. And we can also stay local. This is going to create the vestibulo-ocular reflex. We're going to go up just a little bit. So we're going to head up into the pons. We're going to cross, and we're going to hit yeah, sure. We'll talk about gaze centers, why not? The parapontine reticular formation, if we're talking about turning our head. A gaze center is exactly what it sounds like. It's a little center that has to do with our gaze. Where are we looking? And so we have 4 of these. There's an up, down, left, and right gaze center. Just like the direction buttons on a controller or something like that for a video game. So we have up, down, left, and right. This would be our right gaze center, the paramedian pontine reticular formation on the right side. There's a left one, that's for left gaze. So if we turn our head to the left, let's say, our eyes automatically turn to the right, and that's through the vestibulo-ocular reflex. So we can look at something, and as our head is moving, our gaze stays fixed, regardless of where our head is. So we're able to sense changes in head position, and we translate those to opposite movements in eye position. So if we look to the left and we're stimulating our left vestibular nuclei there, they'll stimulate the right gaze center. From here, we're going to stimulate cranial nerve 6, and we'll stimulate cranial nerve 3 in the midbrain over there on the other side. Cranial nerve 6 is down here. I just didn't leave enough room in the pons. So let's make it a weird shaped ugly pons, and then here's our midbrain. Cranial nerve 3 is going to turn our left eye to the right, left eye right, and cranial nerve 6 will turn our right eye right. And that is your vestibulo-ocular reflex. So the third order neurons are going to be then in the gaze center. I'm going to clean this up just a little bit because we have one last ascending tract, the vestibulothalamic tract. So of course we're going to hit the thalamus. We have to, because we have a conscious sense of where are we. So here's our thalamus. We know our head position, and the only way that we know is because our cortex is active. We have an idea of whether we're balanced or not, and that's because of activity in the cortex. So anything we're consciously aware of has to take place in the cortex. And if you're going to get to the cortex, you've got to go through the thalamus. So the vestibulothalamic tract is going to hit now the third order neurons in the thalamus. And from there, they're going to hit different parts of the cortex. They can hit the somatosensory cortex to tell us, is our head up, maybe a little tilted, am I turning to the left? And then it also hits kind of a hidden area of the cortex called the parieto-insular vestibular cortex. So the insular cortex is going to be hidden by the temporal, parietal, and frontal lobes. Kind of like my undershirt is hidden by the outer shirt here. So if you were to pull open the parietal and temporal lobes there, you'll see the highlighted region in this image, and that's showing us where we create our sense of balance. So we have convergent input from the vestibular system, via the thalamus of course, the visual system, so we can tell our sense of balance based on looking at the world. Are the walls nice and upright? Are they tilted a bit? Are they moving toward me? So visual function is going to be important for our sense of balance. And then we also have somatosensory afferents. what's going on with the rest of my body. That's going to help contribute to our sense of balance as well. Now, our sense of movement is all about relative activity. Do we have more activity on the left or the right? That's what's going to tell us whether or not our head is turning to the left or the right. Now, you can adjust that relative balance of activity by just spinning. So if you spin around, let's say you spin to the right, you're going to stimulate the right side for a prolonged period of time, and your vestibular neurons, just like you, will eventually tire out. So let's say that our baseline balance of activity on left and right is going to be about 3 action potentials for some arbitrary unit of time. Now, as we're spinning, let's say we spin to the right, well, we're going to have reduced output on the left because we're not moving to the left, and we're going to increase output on the right. This is what's going to cause accommodation, or the tiring out of neurons. So that whenever you return back to normal, no more spinning, well, the right side's a bit tired. So it doesn't have quite the same output that it used to, and so you get the sense of movement in the opposite direction. That's what dizziness is. You'll also get nystagmus as a result. Now here we can see a more pronounced case of nystagmus caused by actually damage to the vestibular nuclei. But you can create this without actually damaging anything. Just spin. Or you can put some hot or cold water in your ear, but that's messier and takes a whole lot longer. I prefer just spinning. So by tiring out your vestibular nuclei, you get that imbalance, and you get the sense of movement even though it's not there. This young lady is getting that sense of movement because she has damage to one side of her vestibular system there. That's what's going to create nystagmus, and nystagmus is just correcting an improper vestibulo-ocular reflex. So let's say we spin to the right, we tire out the right side, we get the sense that we're turning to the left. That's going to cause a VOR to move our eyes to the right, and we'll get leftward nystagmus to correct it. So nystagmus is always going to go in the opposite direction of the VOR. All right, just a couple of disorders to hit here. As you can tell, my son is back, so we got to wrap this up soon. The first one we're going to talk about is benign paroxysmal positional vertigo. And this is going to be caused by usually a blow to the head or just the spontaneous flaking off of ear sand, which is a little more common as we get older. So in all these cases, what we're dealing with is either damage to the inner ear or the vestibular nerve, and that's going to create an abnormal level of activity here in our vestibular nuclei, and then create abnormal perception of balance because of that ascending vestibulothalamic tract there. So for benign paroxysmal positional vertigo, this is going to be caused by ear sand dislodging from the otolithic membrane and floating around. If it floats around and finds its way, rather than being here in the vestibule, instead in the semicircular canals, then we're going to create a sense of vertigo whenever we move our head. Because as we move our head, that sand is going to move around. And that sand movement is going to move the endolymph and push on our cupula that are in there. Now the most common sites are going to be the posterior canal here. This is by far the most common site. And that has to do with its position there. It's a lot easier for sand to get in and fall down here than to kind of find its way in the horizontal canal. This will be maybe 10% of the cases. You don't see many in the anterior canal. You'd have to actually try to get ear sand in there. So it's really just posterior canal with maybe 10% in the lateral canal there. And that's because the sand is going to fall downward with gravity. So if it finds its way into the semicircular canal, it's going to go down, not up, and head into that posterior canal. The sand can either hang out in the canal, so it can just float around in here, or it can stick to the cupula, because the cupula is also going to bind that sand just like our macula did. So it's a gelatinous kind of sticky structure. If the little rocks stick to the cupula, we call it lithiasis. That just means cupula rocks. If it stays in the canal, we call it canal lithiasis or canal rocks. So it's exactly what it sounds like. Now whenever we move our head, that movement of the sand is going to create this sense of movement, and that's why we're going to get vertigo with changes in head position. And it's going to take a little bit because the sand kind of slowly floats. So let's think about what happens. Probably easiest to think about it in the lateral canal, but this is still true for the posterior canal. So let's get our vestibule there. We got our ampulla there, and it's going to wrap around. Something kind of like that. There's your lateral canal. So this is going to be most sensitive to rotation left and right. So we can have our sand floating around in the canal or on the cupula there. That's going to give us different sensations depending on where it's sticking. Let's say it's floating in the canal. So whenever we turn our head to the left here, think about what fluid is going to do. Let me draw a bigger canal here. Alright, so there's our vestibule, here's our cupula, and here's some little bits of sand. Now if we turn our head to the left, that's going to push the endolymph against that cupula that way, right? Because we're turning our head. The endolymph is essentially sitting still and providing resistance, so the cupula is going to deflect that way. Now after we've turned, that sand is going to continue to roll on down, creating prolonged fluid movements. And as the endolymph gets pushed by the otoconia there, it's going to deflect our cupula, and that's going to give us a sense of further movement. So it's going to seem like our head continues to turn. Even though we're not moving, the sand is. And that gives us the sensation of moving. That's what creates the vertigo there. We're also going to see nystagmus as a result. So in those lateral canals, if it's floating around down here in the lateral canal, it's going to continue giving the sense of left head turn. So we'll get a right VOR with a left corrective nystagmus toward that affected side. For a cupulolithiasis, it's a little different, right? So let's say we turn our head. In fact, let me go back. So for cupulolithiasis, if the sand is stuck here, doesn't matter where, doesn't matter which side it's stuck to, gravity is still going to pull it whenever we turn left. We're going to actually deflect downward this way, and we're going to deflect our cupula the opposite direction. So now we'll get the sense of right head movement, a left VOR, and nystagmus away from that side. Down here in the long arm, we call that geotropic. And up here, embedded in the cupula, or in this very short anterior arm here, that's also possible. That's going to be our apogeotropic. Alright, so now this next slide will make some sense. The diagnosis and treatment is largely going to be clinical for benign paroxysmal positional vertigo. So to diagnose it, you just need to move someone's head and look for the vertigo and nystagmus that's going to occur. So you just have them turn their head and lay them back like we just saw here. And when you lay them back, you're going to look for nystagmus. So I did an illustration for the lateral canal, but here we're seeing the more common posterior canal. That's going to cause upbeating nystagmus, and you can see a little rotation of the eye as well. That's going to resolve after the sand finally makes its way down and stops getting moved by gravity. So that's why you'll get that prolonged nystagmus with benign paroxysmal positional vertigo. So the Dix-Hallpike procedure that they just showed there is going to be useful for detecting sand in the posterior canal, because you're going to have to lay back to stimulate that cupula. To stimulate the lateral canal cupula, you have to move left and right. So have the patient lay down supine and then just turn their head. And depending on where that sand is, you're going to get either nystagmus toward or away from the affected side, as I already mentioned. The treatment here is, for the most part, just try to roll the sand out of the canal. So you can use the Epley maneuver, where you have the patient lay down and you kind of rotate their head. So you hopefully roll the sand out of the posterior canal and back into the vestibule where it can't do any damage. It'll just float down and eventually dissolve. Only in very rare cases are we going to have the surgical correction here, because there's a high risk for damaging the vestibulocochlear nerve and also damaging the canals there. And as the name suggests, this is a benign condition because it resolves spontaneously in nearly all the cases. Vestibular neuritis is going to be an inflammatory response that damages the 8th cranial nerve. So if we were to have viral and bacterial infection either of the nerve itself or of the inner ear, that inflammation can then create vertigo. It can cause the turning of the body, head, and eyes toward the side of the lesion. So if we have damage on the right there, what we should expect then is to get more of a sensation of kind of a left turn of the head. So our eyes are going to be, because of the VOR, adjusted a bit toward the side of the lesion. Recovery is usually going to occur completely once the infection is resolved. And as we can see in these data, because spontaneous recovery is so frequent, whether you use glucocorticoids or just some vestibular exercises, some balance exercises, you'll see essentially the same level of remission. And the last condition is endolymphatic hydrops. So have a look at the illustration here. On top we can see a cross-section through a normal cochlea. And on the bottom, we see a cross-section through the cochlea and vestibule of a case of endolymphatic hydrops. The blue section in those cross-sections, that's showing us the endolymph. So it's showing us the inside of the membranous labyrinth. That kind of purplish outside, that's the bony labyrinth. So all those little bits of blue, compared on the top and the bottom, you see the swelling of the endolymph very clearly on the bottom. So in endolymphatic hydrops, we have either an excess production of endolymph or we have the inability to properly remove endolymph. And so we get the swelling of the membranous labyrinth. That's going to cause both balance and hearing issues because it will affect the vestibule, the semicircular canals, and the cochlea. So we're going to get our rotational vertigo, we're going to get nausea, we're going to get nystagmus, but we're also going to have just a feeling of fullness in the ear because of that swelling, hearing loss, and tinnitus in its place. The treatment here is to reduce fluid, if possible. So we'll use diuretics, low sodium intake. We can also use corticosteroids to reduce swelling. The final possibility for treatment would be ablation of the 8th cranial nerve. Now obviously this is going to cause lifelong damage to hearing, and will have certainly balance issues until the central nervous system can accommodate for that loss of input from one side. Most cases won't have to resolve with this though, because you'll see resolution of symptoms within about 2 to 8 years. So it's a much longer time span than the other conditions that we talked about. But this is still going to resolve in most cases. And then this cartoon that just came up is just reminding us that we have a vestibule, semicircular canals, and the cochlea, and what we're looking at is a cross-section through the cochlea, so that snail shell there. That swelling in the membranous labyrinth is going to cause then abnormal stimulation of the 8th cranial nerve, and that's what leads to those symptoms that I listed. Alright, so we have a few review questions here. Have a look at those. Anything that doesn't make sense, send me an email, fill out the questions box, and I'll see you sometime this week.